So welcome to the first lecture from Neurosoc. So this one is 3 parts, so they should all be roughly, hopefully, 3 parts. And we're going to do a lecture, which is about 20-30 minutes. Do not move on to this spotter an optional MCQ until you are happy with the contents of the lecture. Now, the lecture, so here's this lecture, we're going to address most of the learning outcomes, and I want to draw your attention to a few things. I will highlight which learning outcome we go through, and we'll go through it in the order at which Moxham presents the learning outcomes. This is Moxham modified, so I've not omitted anything from Moxham, but I've added to it, because Nunc is based on Moxham plus what's at their discretion. But the bulk of marks come from Moxham, so come from this. So this should be your sort of like your go-to. In the top corner here, just use Tunstall's laser pointer, we've got the little brain, and its colour in a traffic light system represents the difficulty. So green, amber to red. So these are nice, easy ones. A lot of this you will have previously done. So, shall we begin? So, let's start with the first learning outcome. What are the sulci and gyri of the cerebral hemispheres? What lobes do they form? So, this is a lateral view. The learning outcome will always be at the bottom here as well, so you know where you are. This is a lateral view of the brain. I want to draw your attention to 2 important points here. We have our central sulcus, and that divides the frontal lobe from the parietal lobe. And then we have the lateral or sylvian sulcus, or fissure it's sometimes called, because it's a lot deeper than the sulcus, the central sulcus. So this lateral fissure here, sorry, I do it a lot, but you should still be able to see it. This lateral fissure here, central sulcus, we have a precentral sulcus and a postcentral sulcus, and these are important because they form the ability for these gyri to be made, which is our precentral and our postcentral gyri. Okay, so the central sulcus, there are 4 gyri in the lateral aspect that you need to note for the frontal lobe. This is our precentral sulcus, our superior, middle, and inferior frontal gyri. Now, our inferior frontal gyri trifurcates into an orbital, a triangular, and an opercular. So I want you to think, when you see opercular, I want you to think of an overhang. So we have an orbital region here, we have a triangular region here, and then this sort of overhangy region here of the inferior frontal gyrus, most posteriorly, is the opercular part. We have an operculum here, we have an operculum here, and then at the base of the precentral sulcus, we have a 3rd operculum. This is called the frontoparietal operculum. Okay, so we have a temporal operculum, a frontal operculum, and a frontoparietal operculum. These are lips that when you pull them apart, so if you grab this lateral fissure and pull it up and down and sort of like peel away and look inside, you will find the so-called 5th lobe, the insular lobe, or the insular cortex, depending on who you talk to. The 6th lobe could be the cingulate cortex, the limbic lobe. So there's a bit of, we tend to say absolutely frontal, parietal, temporal, and occipital, but within this fissure, if we move apart the opercular, we will see the insular, which we'll get to in the more medium and advanced stage. So we draw our attention to that. In the temporal lobe, you need to be aware of these sulci here, the superior temporal sulcus and the inferior temporal sulcus, because this forms the superior, middle, and inferior temporal gyri. Here's a little notch. This is called the parieto-occipital notch, which is all you can see. It forms the lateral aspect of the most medial structures. I'll just put airplane mode on so we don't get interrupted. The most medial structure, which is the parieto-occipital sulcus, which is much more apparent medially, which we'll see in a moment. Occipital lobe here, occipital pole, temporal pole, frontal pole. Now, if we take the central sulcus and go posteriorly, we find this thing called the postcentral sulcus. Connecting the postcentral sulcus to the occipital lobe here is this intraparietal sulcus, which divides the parietal region into this region here and this region here, or the superior parietal lobule and the inferior parietal lobule. Okay, that will become important later. Follow the lateral sulcus posteriorly, and this gyrus here is termed the supramarginal gyrus, and this is Brodmann's area 40, BA 40. Follow the superior temporal sulcus here, and then this corresponding region that wraps around it here is BA 39, the angular gyrus. If you have a lesion of the angular gyrus, BA 39, you have what's called Gerstmann syndrome, which is in the more advanced neuroanatomy. Okay, so that's a quick overview of the lateral aspect of the cerebral cortex. How about the medial aspect? This is often overlooked, but I want to draw your attention to some sulci. Okay, so we have a collateral sulcus here. We have an occipitotemporal sulcus here. Here is our occipitotemporal or fusiform gyrus. This calcarine sulcus is very important because it's the calcarine sulcus, particularly posteriorly, which is the banks of which that holds the visual cortices. The parieto-occipital sulcus has migrated medially here, and you can see it much more prominently. The central sulcus pops around here, but we're not particularly concerned about that for now. We'll see a little bit more detail later. Here's our corpus callosum with our fornix and our septum pellucidum here. Again, don't worry, we'll come to those details later. Which means that if this is our corpus callosum, then we have our callosal sulcus here. We have our cingulate gyrus here. And then we have the cingulate sulcus. If you follow the cingulate sulcus posteriorly, and I just want you to be thinking of boundaries here. So if this is the cingulate gyrus, it's bordered by the callosal sulcus and the cingulate sulcus. The cingulate sulcus does not connect to the central sulcus, but it does connect to the subparietal, which does usually connect to this calcarine sulcus here. So there's continuation there. Oop. So, frontal lobe, just to recap. Superior, middle and inferior frontal gyri that's divided into an orbital, triangular and opercular portion with its inferior aspect. The frontal lobe is comprised of the four gyri, superior, middle and inferior, and the precentral sulcus and its gyrus. On the medial aspect, we have the central sulcus here, and we have a paracentral lobule, and there will be another paracentral lobule here, which we'll get to when we talk about the parietal lobe. We have the cingulate sulcus, and below the cingulate sulcus we have the cingulate gyrus. Then we have the callosal sulcus. This little green superior frontal gyrus continues medially to form most of this. But then here, if you look at the inferior surface of the frontal lobe, we have two different areas, the gyrus rectus and the orbital gyri, which is also called the orbital frontal cortex. Okay, so the gyrus rectus sits laterally to the olfactory bulb and tract here. The orbital frontal sits medially. Oh, sorry, wrong way around. Yes, you get my point. So, posteriorly, we have the central sulcus, we have the postcentral gyrus and sulcus, we have the superior parietal lobule, we have the supramarginal gyrus and the angular gyrus. If you need to find Brodmann's 40 or 39, follow the lateral sylvian fissure and follow that superior temporal gyrus, like so. Now, to go around the back here, we've got that central sulcus, and then we have our posterior paracentral lobule. So the paracentral lobule extends bilaterally either side of the central sulcus here. Okay, so it's one paracentral lobule, but we divide it into anterior and posterior because it's in different lobes. So this portion is in the parietal, this portion is in the frontal lobe. What we then have, if I just erase this drawing here, is we have the precuneus. So we have the cingulate gyrus and a marginal branch of the cingulate gyrus, cingulate sulcus, sorry. The marginal branch of the cingulate sulcus comes off here and divides the posterior paracentral lobule from the precuneus. Cuneus, where have you seen that before? Well, from your block 3 anatomy, you should know the cuneate nucleus, cuneate fascicles of the dorsal column medial lemniscus system. It means wedge shape, and that's because we have a wedge-shaped gyrus here, which is called the cuneus. So this is the precuneus because it's before it. Okay? But again, we'll come to that. So, temporal lobe now. As we said, superior, middle, and inferior temporal gyri. If you go medially, you've got your inferior temporal gyri here. You've got your fusiform or occipitotemporal cortex here. And then just medial to this collateral sulcus, you have the lingual gyrus there. And the lingual gyrus is sat between the fusiform and this little portion here, which is, well, the further extension of the lingual, but it's the further extension of the lingual into the occipital. So the lingual gyrus, therefore, forms part of the temporal lobe and part of the occipital lobe. In the occipital lobe, we've had our precuneus here, then we have our little sulcus here, and then we have our cuneus. Our lingual gyrus carries on here and forms a bit of the parietal lobe as well. And then here is the remainder of the occipital gyri there. So, that other lobe, the limbic lobe, here's a few little structures for you to know. So remember we've said that we have our callosal sulcus, we've said we have our cingulate sulcus, whoa! We have our cingulate sulcus with our marginal branch here. And then our subparietal continues on down here to join the calcarine. Well, here's our cingulate gyrus, and the anterior cingulate cortex is particularly important in pain modulation. We have this region here called the subcallosal area, which is heavily implicated in depression. We then have the uncus, which is where the amygdala hides, underneath there. If you peeled away the uncus, you'd find the little amygdala. Then we have the parahippocampal gyrus. If you peeled that away, no surprises for what you'd find under there. But it means seahorse. So, deep breath. So, let's move on a little bit. So, I just want to briefly mention some Brodmann areas that are of importance. You can go and look up some other names if you're interested. But frontal Brodmann areas, here they all are. Some of them that we'll name here. 44 and 45 form the major part of Broca's areas. And this is, if you remember, two different portions of the inferior frontal gyrus. So revise which portions they are. Clue, that one's orbital. So you've got the other two there. Number 8 here is the frontal eye field, which moves the contralateral parapontine reticular formation to be stimulated, which we'll come to, don't worry. Number 6 here, this is the premotor area. This is involved in the planning of movement. So if you have deficits to it, what's going to happen? Well, you're going to have discoordinated movement, which we'll see in a moment. Then the primary motor cortex here is it forms the bulk of this precentral gyrus. So it's just worth pointing out, actually, that the premotor sort of abuts into the premotor gyrus here. So the premotor gyrus is not just the primary motor cortex, as a lot of people think it is. So by doing this Brodmann association thing here, what we're actually covering is we're covering a functional anatomy in addition to our otherwise topographical anatomy. So the parietal lobe, right, we have our primary somatosensory cortex here, and then we have basically association cortices in the posterior parietal lobe here. So Brodmann area 312, and it is like this. So 3 is closest to the Roland-Darrick's sulcus, then 1, and then 2. And if you look, it's sort of like this kind of thing. So you would have a 3, you would have a 1, and you would have a 2, sort of like that. Yeah, and then we have this intraparietal sulcus, the parieto-occipital sulcus, Sylvian fissure. So this is Brodmann area 40. And then here, all the way, this is our superior temporal sulcus into the angular gyrus there. Now about temporal. Right, so the temporal area here the transverse temporal gyri it's called. This is BA 41, then 42, then 22. This is all auditory. Okay, so this is the big function of auditory. But again, this is just revision for you at this point, I hope. So occipital, we have our parieto-occipital sulcus here, and we have our parieto-occipital notch, which forms an imaginary line between the two to form Brodmann 17, 18 and 19, or V1, V2, V3. This is our primary visual cortex and visual association cortices. If we look medially, I want to draw your attention just to this here. 44 and 45 is Broca's area. 39, 40 and the posterior portion of 22 is Wernicke's area. Now Broca's is supplied by the superior MCA and Wernicke's is supplied by the inferior MCA. They are connected by many fibres, but one of the most important is the arcuate fasciculus. If you lesion here, classically you would be said to get conduction aphasia. It's not entirely true, it's much more nuanced than that, but that is what the textbooks will tell you, and that's what most of the exams will tell you. So, very quick overview of the key things that are mentioned in the curriculum that you need to know lesion-wise. So M1, that precentral sulcus, the primary motor cortex. You will get contralateral paresis and paralysis. Remember, it's contralateral. Premotor, weakness, paresis of the contralateral postural muscles. So they form the basis of the reticulospinal tract. So postural muscles are anti-gravity muscles, they're also called. So they are the things that you will do to resist gravity and hold your posture up in place. If you think about when you stand up, you extend your body up, and it's that sort of movement, that anti-gravity movement of posture that holds you nice and straight, that the premotor cortex will be not able to plan for. The supplementary motor area, contralateral akinesia, you are unable to start, so supplementary S to start. This includes speech. So the supplementary motor area also affects your ability to speak properly, or to begin speaking. Prefrontal cortex is executive. I do have a separate video taken a few years ago when I was at Manchester Uni, the med school, that I uploaded for some student nurses about the prefrontal cortex, so I can link you to that if you want to know. We have primary somatosensory cortex. So that's the sensory homunculus. So you're going to lose all of those different sensations, proprioception, kinesthetic sense, the lot. Primary visual cortex. So this will happen with or without macular sparing based on where you are. The fovea is located more posteriorly. So if I quickly draw a brain here, here is area 17, 18, 19. The more posteriorly the lesion, the more likely it's going to be foveal, which means you're going to have central macular loss. Primary auditory cortex. There's usually nothing because it's very bilateral in nature. Okay, so the ascending auditory pathway merges a lot. So if you have lesion to one primary auditory cortex, it's usually a subclinical finding. So, brief summary therefore of ACA, MCA and PCA syndromes. I've put a thumbs up because that is very core. You can Google that and find it out in 2 minutes. There will be a whole series of lectures on the vasculature that we'll go into in some more detail. So the association cortices, you have primary association cortices and secondary association cortices. And your primary association cortices are more about, well, it's basically what you think. So it's higher level association. We used to think that the primary centres, like your primary motor cortex, was the biggest, most important thing, your primary somatosensory cortex. We think that that primacy means it's the most important thing. But they're basically pretty dumb. They are the things that just follow orders blindly. That the association cortices, which is the great deal in a great mammalian and primate in particular expansion in comparative anatomy. Yes, so 4, this is our primary motor cortex, which carries out the commands to move, but it's 6, and it's a whole host of other regions as well that lay into that motor cortex and tell it what to do, comes up with a plan, tells it to begin, modifies it, and has corrective measures and things like that. And this is the role of the association cortices. The Brodmann areas of importance we've already named. What I will just note here is that you see how 17, 18, 19 exist laterally like this? They're a completely different arrangement medially because they form around the banks of this calcarine sulcus here. So 17, 18 and 19. So that's just something to bear in mind when you're flipping it over and if they point to different Brodmann areas. Localisation of language and dominance. So in almost everybody, even left-handed people, the left hemisphere is the quote-unquote dominant hemisphere, which means it's the fluent hemisphere, which means it's the definition of that is that it is the site of language reception and expression. So we've already mentioned that Wernicke's area exists here. 39, 40, 39 and 22 is posterior bit, and that 44 and 45 forms most of Broca's area. I cannot begin to tell you how much more nuanced it is than this, and how the arcuate fasciculus isn't a part of this, but this is basically analogy. And typical lesions here do cause typical neurological deficits that follow this pattern, so it fits into a nice box for us. But this was the whole learning outcome, so I thought I'd just mention it here. Now, interestingly, they don't really talk about this, but in the non-dominant hemispheres, there is a Broca's and there is a Wernicke's area. Those Brodmann areas still exist, but their function is completely different. So they deal with something called prosody or prosody, and that's about the way in which language, sort of like the subconscious emotional cues of language. So I could say, you know, Broca's could understand that I say hello and then express back hello, but if it's flat of affect, if it's flat of prosody, then that doesn't really tell you a lot. If I say hello, that's a very flat affect, right? That's being expressed by my non-dominant 44 and 45, this prosodic movement. But if someone says a very sad hello to me, then it's my non-dominant Wernicke's side, 40, 39 and 22, that is understanding that. So non-verbal communication takes a massive hit in the non-dominant side in people who have lesions there, or underdevelopment there. Now, internal capsule is very important, and it's something that you need to know very well, particularly its blood supply. So, quick recap here. Here's our ventricle, caudate nucleus, corpus callosum, neocortex up here. Here is our lentiform nucleus, which is our putamen and our globus pallidus. Yep. We have our insula out here, don't worry about all that stuff. Don't need to worry about that yet. Got a hippocampus wiggling around there, caudate tail there, caudate head there, caput means head, cauda means tail. Then we have the remaining ventricle here laterally. So the thalamus is a bit of a blob here, but we're concerned with this area. So the different parts of the internal capsule are the anterior limb, the genu, like genuflect in church, which means knee, the posterior limb, and then there's a retrolenticular region, retro behind the lentiform nucleus, this retrolenticular portion. And then underneath here, getting to the temporal portions here, is the sublentiform. So our retrolenticular is carrying on to the optic region. Our sublentiform travels underneath here to go to this temporal region. This is the lateral sylvian fissure. If you open this up, you find the insular cortex, the insular lobe, sorry, insular cortex rather, but you also find the primary auditory cortex and the auditory association cortices, because we're deep in the temporal lobe here. So the auditory radiations move here. Now, the penetrating branch of the anterior cerebral artery and the penetrating branch of the middle cerebral artery supply the anterior limb. So MCAP supplies this outermost area, MCAP, and ACAP supplies this medial area. Now, the genu is supplied by the MCAP here, and then ICA and ACAP lower down more medially. So ACAP here, Yep. The posterior limb is MCAP, again. And also, importantly, a different thing here, let's have a different colour, the anterior choroidal artery. So we start at the genu with motor, and then we move to sensory. And a very schematic, simple way that kind of works is if at the genu you draw a head, and then you draw a body, and then you do it again, that's basically the somatotopic organisation of the internal capsule. So the motor head is at the genu, motor trunk and limbs is further down, then sensory. So therefore, motor then sensory. So I always remember it as MS, and then two people. It's crude, but it works. Yeah, so MS. So motor up here is mostly supplied by MCAP and ACAP, and then MCAP anterior choroidal. So not too hard to remember. MAMA for MS. Hope that makes sense. The retrolenticular portion going to the octic radiation, no surprise because it's posterior, is the PCAP. Our sublentiform is PCAP and anterior choroidal. It grabs some of this anterior choroidal that's supplying this region here. Right, basal nuclei now. So we're going to do a quick overview of these basal nuclei. Shouldn't take too long at all. So you should know the overall structure of the striatum, which is caudate and putamen. It's called the striatum because the fibres that connect them are stripy. So caudate and putamen is the striatum. Our lentiform nucleus, which means lens shape, is out here. So we have our putamen, we have our globus pallidus. We have our thalamus, subthalamic nuclei, substantia nigra. These are the main players involved in the direct and indirect pathways. Here's another image there if you weren't too clear. And here is a nice little view. So pause the video and have a look at this because we have the amygdala, we have the hippocampus, and it's worth sort of like giving yourself this 3D picture of these subcortical structures. Now, quick overview. So, cerebral cortex, putamen, globus pallidus externus, internus, and the thalamus. Our direct pathway is about upregulating movement. It's about coming into this system, the basal ganglia, or the basal nuclei as it should be called by anatomists, coming to this basal nuclei system to fine-tune and smooth out your movements. Okay? So, if the basal ganglia sends a message ultimately from the thalamus to the cerebral cortex, that is an on signal telling the cerebral cortex, yes, you can go. It's the permission slip for the road trip, basically. So, cerebral cortex sends a positive glutamatergic message to the putamen. I want to move. The putamen sends an inhibitory message to GPI, the globus pallidus internus, which is always the handbrake of the thalamus. And what that means is the globus pallidus internus can't send its handbrake preventing features to the thalamus, which means that because this is cut out, the thalamus can excite and give the permission slip to the cerebral cortex. And that's the direct pathway in a nutshell. So the indirect pathway is the same thing. The cerebral cortex wants to move. It sends a glutamatergic message, an excitatory message to the putamen. But bad news, it's not going to get its permission slip. It will be inhibited in the indirect pathway. So the putamen has made a decision. It doesn't want to let the cerebral cortex move. So how does it do that? Well, it sends a signal to the GPE, not the GPI, which sends an inhibitory message to the subthalamic nucleus ordinarily. So let's work this out. So green, so this is turned on, so it's going to send an inhibitory message to this, which means this message is knocked out, which means the subthalamic nucleus here is not being inhibited. So it can fire, and it does fire. It fires an excitatory message to the globus pallidus internus, which we said was a handbrake for the thalamus. So now this has fired, this has fired, this has fired, so this can fire. If this fires, it means the thalamus cannot fire. So there's no message to the cerebral cortex. It hasn't happened. So just one more time. Cerebral cortex, I want to move. Putamen, you're not going to move, so I'm inhibiting this one, which means this doesn't fire, which means this isn't inhibited, so this can fire, which means this will send the negative impulse. So there's a lot of double negatives here, so it can confuse some people. So the thalamus does not give the permission slip in the indirect pathway. So, a few conditions beyond Parkinson's is for the more intermediate and advanced lectures, and it's getting a bit long in the tooth now. So I'll just make some quick notes to the white matter association, commissural and projection fibres. So, association fibres connect things within the same hemisphere, right? So the arcuate fasciculus we saw before connecting Broca's and Wernicke's is same hemisphere. What about the commissural? Well, this connects things across the hemispheres in the same area. So the corpus callosum is commissural fibres, connecting something from here, across the two hemispheres. Projection fibres project down, so they might be projecting down through the internal capsule or other structures, or that's the insula, but down through the internal capsule into it could be the corticospinal tract, or something like that. So association, commissural, projection, these are white matter tracts. This is how the white matter tracts are organised, and it's something that they really want you to know. So that's the lecture. I'm going to upload the spotter separately because this is getting a bit long in the tooth, but hope you enjoyed it, and we'll see you next time.